discussions at the end. So my presentation's like 8.
Hi, I'm Jens Chapman, and welcome to the Cell Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on free and widely available high-quality content, and as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future if you want to have CME credits. Please do it through the all-access pass.
And we're live in 5, 4,
3, 2,
1.
Hello, everybody. My name is Jens Chapman, and thanks for your attention to our conference here today. So really cool to have you all here. We're usually saying hello from Seattle, but thanks to the Global Spine Journal Club and our great collaboration with AO Spine, it pleasures greatly to have a live spine journal club featuring articles from our Global Spine Journal. So my co-editors-in-chief, Dr. Jeff Wong and Dr. Karsten Wiecher, do you want to come up front for a second? So we're really proud of our content and the engagement of our audience, and we have some of our fantastic reviewers right here. And just wanted to pass the microphone off to Karsten, first of all, about the Global Spine Journal, and then to Dr. Wong to introduce the first of our 5 speakers, to introduce the speaker, but introduce also the concept of what we've gained with 25 years of disc replacements. Karsten.
Yeah, thanks. And we're very grateful that we have the opportunity here to have the virtual journal club. Global Spine Journal is an open access journal about all things spine, and we're one of the highest ranked spine journals, and it's certainly in the open access field as well. And we're happy for your submissions, and yeah, we're happy for this new format, and think it's going to be a very interesting day and very interesting topic today.
And here to introduce our first speaker, but also the man who's created the Global Spine Conference many years ago, and is the spearhead of Global Spine Journal, nobody less than Dr. Jeff Wong.
Thank you, Jens. Thank you, Karsten. So we're coming to you from Rio de Janeiro. This is the 13th annual Global Spine Congress. Every year we travel around the world. We're so happy to be partnering with the Seattle Science Foundation to bring you this Global Spine Journal Club. So without further ado, I know we're limited in time. I'm going to introduce the first paper. Is it somewhere here so I can read it? I'm going to introduce Dr. Dil Patel, who's one of our amazing spine fellows from the USC Spine Center, is going to give us the first paper. Dil?
Thanks so much. Hi from Rio. I'm Dil Patel. I'm one of the spine fellows under Dr. Wong at University of Southern California. I have no financial disclosures. I'll be presenting risk factors for reoperation following single-level cervical disc arthroplasty as utilized in a representative sample of United States clinical practice, a retrospective pearl diver study by Nielsen et al., published in 2025 in AO's Global Spine Journal. Over the last 20 years, cervical disc arthroplasty has become a very popular option for degenerative pathology. It has advantages over ACDF being motion preserving. You don't have to worry about pseudoarthrosis because there's no need for fusion, and it helps mitigate adjacent segment disease. However, since it is a relatively new procedure, there's limited data on reoperation rates and risk factors. So the purpose of this study will be to, one, evaluate the incidence of reoperation after CDA, as well as determine risk factors for reoperation. Methods. This was a pearl diver database study with 161 million patients in the US. It covered all insurance groups. It included single-level cervical disc arthroplasty from January 2010 to April 2022. They excluded additional anterior posterior cervical procedures, as well as patients that had less than 2 years of follow-up. Outcome measures included demographic characteristics such as age, BMI, sex, and comorbidities. They looked at patients that had reoperation within 2 years after their index procedure, also looked at reoperation procedures performed. Statistical analysis included chi-square analysis and student t-tests for categorical variables and continuous variables, as well as multivariate logistic regression models to evaluate risk factors. There's 14,202 patients in this study. 916 had a revision within 2 years, so it's 6.5%. The ones that had revision were older at 47 years versus 46 years. They also had more comorbidities as well. The average follow-up was 5.3 years. There's no difference in sex between revision and no revision, as well as no difference in insurance group as well. This table demonstrates some of the patient comorbidities between the two groups. The ones highlighted in red were actually more found in more numbers in the revision group. So smoking, myelopathy, inflammatory disease, prior surgery, cervical deformity, and trauma were reported higher numbers in the revision group versus no revision. And then the authors ran a analysis looking at the risk factors specifically, and they found in their model that these same 6 risk factors were indeed found to be true. I have listed them in order of highest to lowest odds ratio. So prior surgery, cervical trauma, and inflammatory disorders were the most prominent, followed by deformity, myelopathy, and smoking. Interestingly, there was no age was not a risk factor for reoperation within 2 years. So out of 916 patients that had a reoperation within 2 years of cervical disc arthroplasty, 62.5% needed a cervical fusion, and 49% of these had an ACDF, which is the most common procedure. Interestingly, 28.9% had a subsequent disc arthroplasty, 14.8% had a removal of the arthroplasty, and 3.6% had a removal and then subsequent disc replacement. When looking at a year-by-year reoperation rates, given the index level or year of surgery, there is no difference. So from 2010, 2014, 2018, et cetera, there's no difference amongst the years. So strengths and limitations, this is a large national database study. Interestingly, they included all comers. So these 25% of the patients in this study would not have qualified for IDE trials. So these would be patients that are older than 65 years, had osteoporosis, had inflammatory disorders. They included all comers, which is a strength of the study. Makes it a little bit more realistic in community practice. Limitations including billing and classification error, likely underreported some of the complications. The authors were not able to access radiographic data, operative reports, patient report outcomes, and indications for surgery. They were also not able to investigate the pathology at the index or adjacent segment during the reoperation. So in all, there's about a 6.5% reoperation rate for all-comer single-level cervical disc arthroplasty within 2 years of operation. Most common revision procedure is an ACDF, and I've listed the risk factors here, which are very beneficial for patient counseling when deciding whether they need cervical disc arthroplasty versus an ACDF. So prior cervical history, surgical history, trauma, inflammatory disorders, deformity, myelopathy, and smoking are prominent risk factors. Thank you.
Outstanding, Dill. Thank you. We'll do questions later. And we'll look for Dr. Cameron Hogshead originally from Dallas, Texas. And again, these articles come from the rich treasure trove of our Global Spine Journal, thanks to your submissions, and our fellows had freedom to basically select their favorite articles to celebrate 25 years of disc arthroplasties, a time for critical review. Cameron.
Thank you, Dr. Chapman, for the introduction, and happy to be here and review these articles with you all on Rio. Thanks for having me. It's a real privilege. The article that I'm reviewing is the relative efficacy of cervical disc arthroplasty devices and anterior cervical discectomy and fusion comparison for cervical pathology. This is a network meta-analysis published in the Global Spine Journal and January of 2024. Essentially comparing efficacy of outcomes, specifically one level total disc arthroplasty versus ACDF for treating cervical pathology, which includes myeloradiculopathy, radiculopathy, myelopathy. The aim of the study was to compare patient-reported outcomes, success, complications, and radiographic outcomes that all of the combined studies could fairly compare, and indirect comparisons between the 9 different cervical total disc arthroplasty devices. Motive here was to further obtain understanding of total disc arthroplasty devices, specifically the nuances of the designs, and potentially enhance surgical indications and device selection. These were the patient characteristics and inclusion criteria between the study analyses that they chose. At minimum, randomized control trial comparing cervical total disc arthroplasty to ACDF, and patients who underwent index surgery only had a single motion segment, and included total disc arthroplasty patients with at least 45 patients and at least average 2-year follow-up minimum. And exclusion criteria between the articles were early results of clinical trials that later reported further follow-up were excluded, and studies reporting the same outcomes on the same patients elsewhere. They had 15 randomized control studies that met all of these requirements, which resulted in about 2,643 patients. Average follow-up was about 5.5 months with, as we mentioned, 2-year minimum up to over 6 to 10 years. There's a fairly fair distribution in terms of half underwent total disc arthroplasty and close to half, a little less than half, underwent ACDF, and the 9 total disc arthroplasty devices that they were comparing were shown there: the Bryan, Discover, Kineflex, M6, Mobi-C, PCM, Prestige, ProDisc C, and Secure C. So the results broken down, you can direct your attention to the right on the graph, and they looked at neck disability index with 8 studies that met fair criteria and sufficient data between the 5 devices there. And you look at direct comparisons that showed no single total disc arthroplasty device significantly outperformed ACDF for reducing neck disability. There was no differences, and then indirect comparisons between devices had similar results for NDI. You look at the VAS neck and arm, 8 studies met comparisons with the 6 total disc arthroplasty devices that you see there. Really, for the neck and comparisons, they're all similar outcomes between total disc arthroplasty and ACDF. As for VAS of the arm, the M6 device you can see there actually performed significantly better than ACDF in reducing arm pain. And there were really no indirect differences between the M6 and other total disc arthroplasty devices in this regard. The CSPRO that you can see there, there's 5 studies that compared these devices, and the M6 device again actually performed significantly better than ACDF in improving physical health status. Between the devices, there was really no significant changes. Overall success was basically defined as no implant procedure-related adverse event, neuro maintenance, motor scores, or improvement, NDI improvement, no device failure, or supplemental index level surgery for that device. And there was really no differences in overall success between the devices or when compared to ACDF in general. Neuro success, similarly, all devices were better than the Prestige and performed better than ACDF. But M6 specifically, as you can see there, is highlighted in yellow, outperformed the Bryan, Mobi-C, and ProDisc. And then satisfaction is they defined for patients surveys with VAS and categorically survey, the Mobi-C and Secure C significantly outperformed the ACDF and the PCM and specifically in the VAS. And indirectly comparing the devices, there was no significant differences between them. Dysphagia, you can see there, if you direct your attention as well, M6 significantly lower than ACDF that only had 3 devices to compare between here that met all the criteria, and M6 was shown better to be than the Bryan. Adverse events, there was similar comparisons and no significant differences between the devices and between the total disc arthroplasty device and ACDF. Looking at index level SSI, which is supplemental surgery for the index level, the Bryan and Mobi-C devices significantly fewer surgeries than the other devices when indirectly compared. And then the Mobi-C specifically compared better than the PCM. Similarly, for adjacent segment surgery, you can see the Bryan, the Mobi-C, and the PCM were significantly lower adjacent segment than the ACDF. And then when comparing all the devices, the significant that you can see there on the yellow on the D in the stage, the MobiC performed better than the M6 and Discover. Looking at bridging bone and heterotopic ossification between, obviously you'd expect with an ACDF to have that. And so these were just indirect device comparisons between the total disc arthroplasty, and they actually found that M6 was lower than Kineflex, MobiC, PCM, and Secure C. And then looking at segmental range of motion, there was no indirect device differences, and all the devices significantly, as you'd expect, more range of motion than the ACDF. Interestingly enough, the PCM and the ACDF ended up having not much range of motion differences. This was a very cool map that compared p-values of the different devices amongst themselves in terms of all of those parameters, PROs, as well as radiographic outcomes between and successes. So the heat map, basically, the more green, as you can see with a 0.99 for the M6 and dysphagia, the better. And the ACDF in the first column, as you can see between the p-values, was significantly outperformed by pretty much all of the devices. You can see the M6 there was a top performer, MobiC, Prestige, as was compared in the ProDisc. You can see on the right is also just a different illustration of the performance of the cervical disc arthroplasty devices and how they perform M6 Secure C on top. So discussion here, cervical total disc arthroplasty is once again shown non-inferiority to the ACDF. And actually in this study, several devices with superiority to the ACDF. Can we really conclude that the M6 is superior to other devices or the Discover is most inferior? Really hard to say because this is an indirect comparison. And so we need further studies to really direct that. There were some differing inclusion and exclusion criteria between the studies. And non-homogeneous patient population, which could skew the significance of that comparison as well. There was also different follow-up between the studies. Maybe the M6 looked a little bit better on bridging bone performance because there was only 2 years follow-up versus others that had longer follow-up. You could expect more heterotopic ossification and bridging bone. I think future studies need to directly compare cervical total disc arthroplasty devices in a random but controlled setting. Thank you.
All right, thank you very much. And I'm happy to call up the next speaker, Dr. Joris Gerstmeier from Bochum, and he will tell us about long-term survivorship and an article we published recently.
Yeah, thank you very much for the kind introduction. My name is Joris Gerstmeier. I'm trauma and orthopedic surgeon from Bochum, Germany. I'm proud to present the long-term survivorship of cervical spine procedures, a survivorship meta-analysis and meta-regression analysis. So just a quick background, around 30 to 50% of all adults will experience neck pain at some point in any given year. And out of those, 50 to 80% will develop chronic symptoms. At around $150,000 US, the cost of undergoing spine surgery is very significant, with up to $5,000 to $30,000 per additional procedure. At the moment, secondary revision surgeries are more increasingly performed than primary procedures. So there's a need to investigate the survivorship of ACDF, ADR, laminoplasty, and posterior laminectomy and fusion. Previous studies predominantly focused on risk factors for revision rather than the probabilities of revision. So the objective of this study was to conduct a meta-analysis on the survivorship of commonly performed cervical spine procedures to develop survival function curves for revision surgery at any cervical level and at adjacent level surgery. So the authors did a meta-analysis including degenerative spinal pathologies treated in primary surgery with more than 20 patients concluded and follow-up of more than 4 years with at least 2 procedures comparing, so ACDF, ADR, LAMP, or of posterior fusion. The exclusion was focusing on special cords only or single arm studies with endpoints secondary surgery at any cervical level or adjacent level surgery. So overall, the authors identified 1,829 studies and included 16 8 for second surgery, and for fibroization level surgery, with over 70,000 patients included for secondary surgery analysis, and roughly 2,800 included for adjacent level. So this is the first result summarizing the survivorship graph over 350 months for ACDF, ADR, LAMP, and DIF. So this is revision at any cervical level, and you can see that the laminoplasty almost has a perfect line, and ADR had an increased risk of 70%, and LAMP and decreased risk of 94% compared to ACDF. These are the total numbers. You can see that the laminoplasty almost had a perfect survivorship, with fusion being the worst performer overall 10 years period. This is a secondary comparing adjacent level surgery compared to ACDF. In this graph, only ADR can be compared because there was a lack of data included. And compared to ACDF, the risk for adjacent segment with ADR was decreased by 75%. Again, the total numbers over a 10-year period demonstrating clearly that ADR had a better survivorship compared to ACDF. So in conclusion, the second surgery durability, ACDF, ADR, and posterior fusion all showed very similar reoperation rates, so survivorship of around 98 to 93%, but no statistically meaningful differences, although the laminoplasty is the only exception with a near complete durability at around 99% at 5 years and close to that at 10 years level. With the adjacent level protection, the ADR significantly lowers the adjacent level reoperation risk compared to ACDF, with a consistently higher free survival curve at every point during those 10 years. So considering a laminoplasty should be if we want maximal reoperation durability is the goal and if it's indication. And between ACDF and posterior fusion, the authors concluded that there might be a modest better survivorship for ACDF rather than comparing to posterior procedures. Motion preserving versus fusion is always a high discussion, and ADR shows benefits compared to fusion there as well. The limitation of the study is obviously there's a heterogeneity of various sources, so various patients and various surgical techniques for stenosis and regulopathy. And there's also some sparse data. So for example, laminoplasty and posterior fusion were underrepresented in the adjacent level studies. So that's why they were not included. And there's also death or non-surgical endpoints were not included, which limited general visibility. Overall, they also had mixed indications, as I said, a mixture of radiculopathy and myelopathy, which may influence the results as well. So further studies are needed. Thank you so much.
I want to really credit our fellows from USC and from Seattle for their terrific discipline and staying on time. And it's a great honor to introduce one of our colleagues from USC, Dr. James Yu, and he's going to talk about heterotopic ossifications, another overlooked and concerning thing, relationship to spondylosis. Thanks for selecting the article.
Thank you so much. Good afternoon. My name is James Yu. I'm one of the fellows from the University of Southern California. Very excited and grateful to be at the Global Spine Congress in Rio. Today, I'll be presenting an article submitted by or written by the group in West China Hospital last year in 2024 called The Effect of Preoperative Cervical Spondylosis on Heterotopic Ossification After Cervical Disc Replacement. So the main benefit of cervical disc replacement is motion preservation and reducing the stress transfer to the adjacent segments. However, the heterotopic ossification after CDR is an adverse outcome that may reduce motion and even potentially progress to inadvertent fusion. And other studies have demonstrated that preoperative spondylosis is a risk factor for HO. However, there is limited data on the components of preoperative spondylosis that is relevant for HO. So the objective of the study was to assess the elements of preoperative spondylosis and their effect on the extent as well as location of HO after cervical disc replacement. This was a retrospective study by a single surgeon with cases from 2009 to 2018 using just the Medtronic Prestige LP model, which is in the photo right here. And there were 149 patients included with a total of 196 disc replacements. The inclusion criteria were patients in the ages 18 to 65 who underwent either a single level or two-level CDR between C3 to C7 for cervical myelopathy or radiculopathy. None of these patients had postoperative non-steroidal anti-inflammatory drugs. And the minimum length of post-op follow-up was 24 months. The exclusion criteria were patients with gross instability, fixed kyphosis, ossification of the posterior ligament, and osteoporosis. So the group really used the Wall-Ravens spondylosis scoring system to do the preoperative evaluation, which shown here involves three elements here, including the disc height loss, the anterior osteophyte formation, which shown in the photo here is the size of the anterior osteophyte as a ratio in relation to the vertebral body diameter, and end plate sclerosis. And other features considered were oncovertebral osteophytes on the coronal CT, as well as facet joint degeneration. And the primary outcomes were mostly radiographic, the first being the grade of ossification using the McAfee classification, which they had 4 grades, and they were divided into low versus high grades. So the low grade involved ossification occurring outside the planes of the end plates, or if they were within the end plate region, the range of motion was not affected. For the high grades, grade 3 had the range of motion that were limited by the ossification or had already progressed to fusion. Other radiographic markers were the location of HO, so anterior versus posterior disc space. And then adjacent segment degeneration, which was defined as narrowing of the disc space at the adjacent level that is greater than 10% loss of their baseline, or neuroenlarging osteophytes, as well as segmental range of motion. The secondary outcomes were clinical, so they were looking at the Japanese Orthopedic Association score for myelopathy, neck disability index score, as well as pain for patients who were presenting with neck pain and radiculopathy. I'll skip this slide for the sake of time. Looking at the results here, the ossifications were really put into 2 categories. The first being the grade, so low grade being 44.9%, high grade being 14.8%. And then location of the HO with the anterior disc space being 22.9% and posterior being 41.8%. And looking at the demographics, the mean age was 43, of which little over 50% were female patients, and about 2/3 of the patients had a single level CDR, and the most common level was at C5-6. And briefly, these age, sex, or surgical level really did not have any significant relationship with the risk of HO. This table showing the anterior versus posterior, and this table showing low versus high grade, none of them had statistical significance. But looking at the preoperative spondylosis, there was an association between disc height loss, anterior osteophyte, oncovertebral joint osteophyte, and facet joint degeneration with the formation of posterior HO. However, no significant association with anterior HO. And if we look at the mean scores of spondylosis for disc height loss or even facet joint degeneration, you can see that grossly they're all fairly low scores. So this suggests that patients who had severe spondylosis were already excluded from the patient selection process before the surgery. And then when they did the multivariate analysis, there was it showed that only the disc height loss was significantly associated with posterior HO formation. When we looked at the low versus the high grade HO, again, only the disc height loss was associated with high grade HO risks. And so what does all that mean when it comes to clinical translation? Are the patient outcomes affected by these HO? And in their study, in terms of patient-reported outcomes, such as JOA, neck disability index, and pain, there was no significant relationship between that and the location of the HO, whether it was anterior or posterior. And also, there was no significant relationship between the global range of motion defined as C2 to C7 range of motion for the location of HO as well. However, when patients had posterior ossification, there was an elevated risk of adjacent segment degeneration. And then looking at low versus high grade ossification, again, not a lot of significant difference between JOA, the neck disability index and pain, compared to low versus high grade ossification. And interestingly, the adjacent segment degeneration was also not really associated with the grade of the HO. However, the range of motion was more diminished in high grade ossification. So the summary of their findings were that preoperative spondylosis really affects HO in the posterior disc space, and more specifically, the disc height loss was the only independent risk factor, and there was no significant relationship between ossification and patient-reported clinical outcomes such as pain and disability. However, high-grade ossification did reduce the range of motion, and posterior disc space ossification had an increased rate of adjacent segment degeneration. And then their suggested optimal cutoff for disc height loss for cervical disc replacement was 18.5%. So anything greater would be an elevated risk of ossification. This was a fairly comprehensive study looking at the different aspects of spondylosis and their independent association with ossification risk, and a fairly unique focus on the location of the ossification of the disc space, and also looking beyond the radiographic outcome to looking at clinical relevance of ossification. It is limited in that it's a retrospective review with a single surgeon study and looking at only a single disc model, the Prestige LP. And then the follow-up was limited to 24 months, which may not be long enough to look at the long-term effect of ossification, especially since we were seeing that patients were already developing some adjacent segment degeneration, even though it was not reflected in their pain or disability score yet. However, I would say that the 18.5% is a useful number to help us guide in our clinical decision making. And then, future multi-institutional long-term study would be helpful in getting further data. All right, thank you.
Thank you very much for this insight, and I'm happy to call up Dr. Igbeniji from USC to elaborate about an article published on the topic of segmental kyphosis.
Good afternoon from Rio. My name is Matthew Igbeniji. I'm a spine surgery fellow at USC. I have the honor to present on segmental kyphosis. The study titled, "Are patients with segmental cervical kyphosis appropriate candidates for cervical disc arthroplasty? A clinical and radiographic analysis compared to ACDF." I have no disclosures. The primary aim of this study was to compare clinical and radiographic outcomes from ACDFs compared to disc arthroplasty at 1 or 2 levels. The secondary aim was to assess the appropriateness for disc arthroplasty in patients with segmental kyphosis. It's a single center study out of New Jersey. It's a retrospective cohort looking at patients between 2017 to 2020. They had about 48 patients equally distributed between the arthroplasty group and the fusion group. Patients were included if they had 1 or 2 level disease that was addressed with segmental kyphosis at the level that was treated. Any patient with rigid fusion, ankylosing spondylitis, instability, or severe osteoporosis were excluded. They looked at patients for about 24 months on average. In terms of the funding of the study and conflicts of interest, there were no specific grant funding for the study, IRB approved. In terms of disclosures, there were no relevant conflicts in terms of the authors. And so when looking at the demographics of the patients, about 62% of the ACDF group were male, and about 33% of the disc arthroplasty group were male, which was statistically different. Otherwise, in terms of age, BMI, diabetic, or smoking status, there was no significant difference. Now, looking at the implants, there were 3 implants used that are listed here that weren't really reported in terms of significance and bias towards one or the other. And for all ICDFs, there's a structural interbody structural interbody with PEEK or allograft, and they all used an ACDF plating system. The selection was based on the surgeon's preference. And so when looking at perioperative outcomes, there were no significant differences between the groups. They looked at EBL, length of stay, operative time. In terms of functional outcomes, they looked at the NDI and the visual analog score, visual analog scale, and they found a significant difference in the NDI in favor of disc arthroplasty, but the visual analog scale provided no significant difference. In terms of radiographic outcomes, they didn't really see a statistically significant difference in terms of lordosis pre and post-op. In terms of, and that's as it relates to cervical, the segmental or regional lordosis pre and post-op. In terms of complications, they looked at overall complication rate, which was not statistically significant, but biased towards ACDF. They looked at transient dysphagia, which also was not significant between the two groups. Dysphonia, infection, none were significant between the two groups. However, they looked at HO, which was statistically significant in the disc arthroplasty group, which to me makes sense. And in terms of adjacent segment disease, it was biased against ACDF, which also was pretty intuitive. Reoperation rate was 0 in both groups. So although a very well-designed study or a very informative study, there are a bit of limitations. It's retrospective in design, very small cohort of 48 patients. It has about short to midterm results without any evidence of long-term results. And device-specific performance wasn't really assessed. The other thing is, in terms of their radiographic preoperative assessment, they only had static radiographs without dynamic radiographs, which we know could provide more information in terms of prediction of failure. In terms of the clinical implications of this study, I'd say it shows that disc arthroplasty, again, is a viable alternative to fusion, and that the existing contraindications are currently reasonably being challenged. And I think radiographic outcomes, complication rates are comparable between the two. So it's always going to be interesting to see how we move forward with disc arthroplasty and treatment of these patients. And thank you.
Excellent presentation. Thank you, Matt. So first of all, round of applause for all of our 5 presenters. Stayed on time, highly succinct information, and really cool information. They'll be available for specific questions. Before we go into the questions to the presenters, Dr. Scott Blumenthal, I have a special guest here. Can you come up to the podium, please? So this is a bit of history. This is a surprise guest. He's actually done the first disc replacement 25 years ago, and he's the host of our quarterly spine arthroplasty forum at SSF. And he actually presented the very first patient who in the US got her disc arthroplasty 25 years ago, thanks to you. And it was a very amazing, emotional moment because she was super happy. So Scott, you saw 5 excellent articles, thanks to our authors from the Global Spine Journal. And before I forget it, I want to make a shout out to Donnie Lieberman. Donnie, this is our managing editor. She's a goddess of our journal. So she truly does an amazing job. Thank you, Donnie. So Scott, you heard these 5 excellent articles. What are some thoughts in terms of the insights that these various articles give us in the big picture?
Thank you, Jens. This isn't my analogy, and one of my kind of 40,000-foot view thoughts is there were a couple papers doing systematic reviews, things like that. And the analogy on those that, again, isn't my analogy, is what a systematic review, the big data is a huge lake that's really shallow. So you can gain some trends, you can learn a bit from it. I want to do that in contradistinction to the SC study on the prestige, specifically looking at HO. To me, that's a really small well that goes a few hundred feet down because there was very specific questions asked and very definitive answers given. I do have one specific comment on the Phillips paper, which was one of the meta-analyses. I thought it was really interesting that half of the discs are off the market now that are in that. And it just goes to show long-term follow-up is the key. Short-term follow-up, we can learn enough to get FDA approval, but these post-approval studies and really kind of keeping an eye on things is really important. My question on the Prestige LP study. So it's, and again, very, very specific information, deep dive. And this is a really subtle point. The Prestige LP has a positive stop. So it's not surprising that sometimes the posterior part of the disc space is uncovered, which would make it more susceptible to HO. We all know we want to get as big a footprint as possible on the disc space. So I don't know if when you guys has any comment on the fact that could that be potentially an etiology as why posterior HO was, or posterior osteophytes or posterior bone had an increased incidence of posterior HO in follow-up of that specific disc. And I wonder if it would be, if it was a multi-disc study, if posterior and anterior HO would make a difference. Any comments?
So great points. Let me ask a question outside of the disc arthroplasty environment. Dr. Wang, could you come up for a second? I really like the Mohammed Faraj paper about survivorship. And there was a procedure done that I love and I really appreciate, thanks to you and your teachings and that of Dan Rue, laminoplasty. Are we forgetting a really valuable procedure that had literally no failures over time?
Yeah, so you bring up a very interesting point because I love laminoplasty and I think laminoplasty is a great surgery. I've seen a change in the thought process for laminoplasty since disc arthroplasty. So when you think about before we had cervical disc arthroplasty, we had fusion, right? And if you have a patient that has multi-level stenosis and you're going to fuse multiple levels and you can get away with doing a laminoplasty, huge advantage, preserving motion, doing a laminoplasty. So it was very easy for patients to buy into that. And for years and years, that was like the thing that the patients loved. And when they came to me, they were like, oh, I can preserve motion. Then disc arthroplasty comes and you can preserve motion going anteriorly. And so I've seen the interest in laminoplasty, at least from a patient aspect, go downward since the advent of disc arthroplasty. And I saw a physician just a few weeks ago that needs a 2-level cervical decompression, but also has congenital stenosis. And, you know, I offered him a laminoplasty, but he's more interested in doing a 2-level cervical disc replacement, even with some degeneration at the adjacent segments, which likely will decrease. And so I think that because of the advent of disc arthroplasty, the interest in laminoplasty has gone down. However, there's another phenomenon. People think that laminoplasty is more involved in a bigger surgery. Number one, because it goes through the posterior muscles. And number two, you have to do multiple levels in order to expand the cord. And I remember early on in my career, I would see single level disc herniations that we would normally do in ACDF. You go to Japan, they do a laminoplasty. And I would sit there and say, oh my gosh, a single level ACDF versus a laminoplasty, but they have a lot of congenital stenosis in Japan. And they were thinking down the line that I want to do a laminoplasty to take care of this problem, to prevent problems in the future from coming on. So those are my thoughts on why laminoplasty, at least from a patient perspective, are not as attractive, but they used to be very attractive.
Great. So let's go into detail and we'll keep Dr. Blumenthal up here. Dr. Patel, can you come up here? So again, the question was reoperation, single levels. So tell us a little bit about loosening and infections. We have a person who has a very large database at TBI, and then I'll ask Scott to comment on his Texas Back Institute data. So infections and true loosening of a device with foreign body reactions was a big deal. What is your memory of that particular complication again?
Yes, one big caveat or sort of downfall of this paper was they did not look at very specific reasons for the complication. So I defer to Dr. Blumenthal to kind of go over what his experience is with that. Yeah.
So it's interesting in comparing, and again, I'm going to go back and forth a little bit. In the paper that was comparing disc to disc, the nice thing is of the studies, the level 1 studies, and it's the only device that I think has this, is every study has NDI as one of the outcomes. So you actually can compare between different prostheses. I think it's going to be interesting in terms of the complications when we start to classify the prostheses, their biomechanics, how they move, what their constraint is, the biomaterials, which lately has proven to be really interesting to us because we're seeing higher failure rates in certain biomaterials. And it's not so much loosening infection. We're seeing osteolysis, and that's probably related to wear of certain materials. It doesn't appear to occur as frequently with the cobalt chrome polyethylene discs. But once you kind of once you move out of that lane of very, very tried and true materials, you have to be really careful. And You know, we jumped on a lot of these things from a IDE standpoint and clinical adaptation, and some of it's come back to kind of burn us in the end, which is why we have our series of failures that we'll talk about at the symposium tomorrow. So come to tomorrow's symposium.
Quick question, then we'll go to the next author. So there are different disc arthroplasties, not just in terms of material, but also in terms of their stiffness of design. Dr. Patel, did they sub-differentiate or try to differentiate the unrestrained from the semi-restrained discs?
No, it was all comers, all implants. They didn't specify one implant versus another, which is another caveat as well.
So Scott, is there a sweet spot of restraint mechanism? And you mentioned, for instance, the Prestige has a block at the end. So how loose or how rigidly constrained should a disc replacement be?
You know, I think it's going to depend as we get more and more data. I think it's going to depend on level specific, age specific, presence of kyphosis or not kyphosis, greater than 20% disc space height loss versus not. I think, you know, and constraint is a weird thing because it's not end plate fixation. It's how many loci of motion there are. Ball and socket versus, unconstrained, relatively free polyethylene like a Mobi, but in a stiff spine, Mobi's a great device. In a loose hypermobile, not so much. So I think it's going to be device specific, level specific, and patient specific.
And certain sports like contact or collision sports versus the hobby athlete, any preferences?
Well, kind of a priori, you would like the more constrained. We had this Delphi analysis that we did in Seattle a couple of years ago, and that seemed to be the consensus, but that's in the absence of real good data.
Thank you. So let's go to Dr. Hogshead. Come up here. Thank you, Dr. Patel. Dr. Hogshead. So again, we talked about the laminoplasty thing, which actually really surprised me because until this journal club, this is the Value for Journal Club, I did not know of that study. I did not pick up on that. I'll ask you, what is your thought on disc replacement versus fusion in terms of survivorship analysis? Was it something that surprised you, like the years of delay in terms of when that occurred? And then we'll pass the microphone to Dr. Blumenthal for commentary.
Yeah, at least in this paper that was reviewed by Phillips and compared different devices, they show that reoperation rates were significantly lower with the total disc arthroplasty device. And just kind of stress that with ACDFs, you worry a lot more about pseudoarthroses, hardware failure, and subsidence, and more than you would with total disc arthroplasty, which is kind of something that's been echoed in the literature as far as ACDF or total disc arthroplasty being non-inferior to ACDF in terms of reoperation. So it was surprised to see that even in the M6 study, which had just 2 years of follow-up, showing significantly better in that regard and overall success. So.
Yeah, the literature is replete with a lot of studies, and the studies that show a decreased rate of reoperation with disc replacement far outweigh the other ones. I know Pierce Nunley's here. He wrote one of the first papers kind of showing the opposite, but this was more than 10 years ago. I don't think he believes that anymore. Reoperate, and again, it's very technique specific. You think that arthroplasty is technique specific, now compared to when Jens and I first started for ACDFs, we've got these very short plates that stay away from the end plate above and below. And I think we see less adjacent segment with really good ACDF technique as well.
One more question to the expert. So Cameron showed that the M6 disc, which is now not on the market anymore due to osteolysis concerns, had a lower dysphagia rate. Dysphagia, the Italian, swallowing difficulties. Why would that be?
That is the easiest question you've asked me. Of all the studies in Frank Phillips' meta-analysis, that was the most recent one. So the surgeons, many of which were on all the studies, were way down on the learning or way up on the learning curve by then. That's the 6th or 7th study we all did. So hopefully we're getting better.
Great. Thank you. Moving on to Dr. Gerstmeyer. So again, the laminoplasty was actually in your thing. Yeah. Tell us about Germany and the adoption of disc arthroplasties. I hear that this is not the preferred surgery. For me, it's a preferred surgery over a fusion by far, if I can help it. How is the acceptance in Germany when you see these kind of survivorship analyses that do favor disc arthroplasty?
Well, tough question for me. My institutions, we don't do them. So I have a lack of personal experience in that. I can't really answer that. I'm sorry.
So how is this working now from your end? It's Pierce? Okay, that's funny, yeah. So disc arthroplasties, if you have to nowadays argue with insurance companies, this is a study that basically hits a home run, right?
You know, if in the US, insurance companies make you stay in your lane, so they don't like paying for off-label stuff. But if otherwise you kind of follow accepted indications, that's almost gone away. But once you try to say, okay, this guy's got a 3-level fusion, broke down again, I want to do an arthroplasty because I don't want this patient to have a 4-level fusion. And they say, no, we'll only approve a fusion. You pull your hair out. And that's the big frustration, is thinking out of the box. So
Tell us quickly, this is not part of this study, about cost efficiency of disc replacements versus a fusion. So what's the direct side-by-side cost? What's the return to function?
from a cost standpoint, you know what you're getting. Usually your hospital system has negotiated a price for a prosthesis, and whether, you know, it's a pro disc or a simplifier, whatever the hospital says, this is what we pay, you know, so you know what you're going to get. With a fusion, you can do a cage with nothing in it, like sometimes they do in Europe. You could do allograft and a plate. You can do a titanium cage with a biologic, a synthetic biologic and a plate. I mean, there's a lot of add-on costs, and, you know, unfortunately, the incentive in the US is to keep, you know, adding on.
So Dr. Gerstein, he actually, Gerstmeyer showed that case of his at the very beginning, the Sports and Spine Conference. And hi, JJ, good to see you. And he's a competitive world-class rower. What would you, now knowing what you're knowing and seeing in this article what works, what would you have for yourself if this is your spine? Actually, you showed your case. So what would you have done?
Well, I had a lumbar problem, but in cervical spine, when we need to, I think, take a little more, dive deep into this analysis, it would have been great if they included the pathology, because they kind of mixed all radicalopathy and myelopathy both. So from that article, I would opt in for a laminoplasty.
Yeah, no, that's certainly a surprise. Dr. Yu, do you mind coming? Thank you, this. So Dr. Yu, you raised a very important point, that is heterotopic ossification. The other day, I saw my 20-year follow-up on a cervical disc arthroplasty. I'm going to show them tomorrow in our spine arthroplasty section that's chaired by Dr. Blumenthal. I'm going to show that patient. I'm always asked the question, is that guy still moving? Now, you raised the question of disc collapse and spondylosis as a risk factor. So how does this work in your practice when you present a case to Dr. Wong for a surgery or not disc replacement? Do you automatically measure the disc height and have that available?
You know, whether it's ACDF or ADR, you know, Dr. Wong does like to kind of compare the adjacent levels and see, you know, is that specific level disease, is the facet disease, you know, is there a lot of motion or not a lot of motion? So it's definitely part of our routine practice to include the disc heights, whether it's replacement cases or ACDFs or any other case.
So if I understood the study right, and I'm competing with saws here in the background, I apologize. If the disc is less than 1/5 of the normal height of adjacent segments, that's a possible no-go. Is that right?
If the disc is decreased by almost 20%, then it would be a no-go according to the study. Yes.
So Scott, so I divide human beings, we humankind divide one another in many different parameters. I'm not going to philosophically, politically wax here, but you can guess. But I divide humankind in 2 categories, bone formers and bone non-formers. If they have a hypertrophic osteoarthropathy or something like that, how much is that a contraindication? How much is this disc height loss something that you would say this is no-go?
And I agree with you. It's probably because we've talked about it, but young people that have flowing osteophytes younger than their age should dictate. That's a red flag, and it requires a really serious conversation if the patient's coming in for a consult for arthroplasty. I think disc space height loss, degree of spondylosis, having an increased incidence of HO also goes on with age. So we found, we did a study looking at some of our older cervical arthroplasty patients, which were more spondylitic, tend to lose a little bit of lordosis. And we found that although the clinical results or adjacent segment changes didn't seem to make a difference, those patients did have more HO in the older, more spondylitic group.
Did the authors, Dr. Yu, account for anti-HO prophylactic medications like the famous indomethacin protocol or something like that?
So all the patients did not get postoperative NSAIDs, so none of them got it. And then they did not, go into detail about the rationale for not keeping these patients on NSAIDs postoperatively.
I still give the old FDA protocol, indomethacin protocol. Scott, am I out of line?
No, I mean, the original IDE studies, since they were randomized to fusion, none of those patients got it. And have we made a big difference? We still give patients actually over-the-counter anti-inflammatories. We don't use indocin, but we still do it as part of our normal postoperative regimen. Love to see some good data on it. I think genetics has a big part of it, as you were alluding to with bone formers and not. But again, from a clinical results standpoint, it just doesn't seem to make a difference. And I find the some of the databases interesting, like the MAUD database has I don't remember what the percent is, reoperations for HO. I don't think I've ever reoperated on somebody for HO, because your unsuccessful arthroplasty is successful fusion. What are you going to convert it to? I don't know.
Great. Thank you, Dr. Yu. Last but not least, Dr. Vindiji. So thanks for this great talk. This is one of the great controversies of disc arthroplasty. Can we improve lordosis with a disc arthroplasty or fusion in a better, more meaningful fashion? If you had to have a disc replacement after what you've studied, learned, seen at USC and read, what would you have? And where is the cutoff of a segmental kyphosis for you after reading this paper?
And so for me, I'd say that my study looked at analogous studies. They had comparable results. And so I'd say I could trust the results relatively from the study that I presented, and I would opt for arthroplasty if I don't have, congenital stenosis. I've never got an MRI, or severe arthrosis above or below, or any other contraindication to getting an arthroplasty that we know. I think arthroplasty outpaces a fusion single issue level. Second question.
So I'll go there. I'll refine my question. Thanks for that opportunity. If a patient has a fixed kyphosis versus a dynamically unstable kyphosis, an acquired kyphosis that reverses with extension, did the authors look into that?
And so that's what I was saying. They didn't get dynamic radiographs, which I thought would have been very helpful. There is a study that suggests high dynamic kyphosis, segmental kyphosis, is a risk factor for HO. And so that would have been useful if the study included that.
Scott, yeah, so the question is restoration of lordosis, disc arthroplasties versus fusions, and are there some tips and tricks to achieve that with a disc arthroplasty?
All right. So each time I reference another person here, they show up. So I'm going to reference Izzy Lieberman, who states to the fellows that life is a kyphosing condition. As our discs degenerate, they're all going to lose some segmental kyphosis. Now, unfortunately, there are guidelines for when a cervical spine's too kyphotic to do, for example, a laminoplasty. This question came up earlier because Dr. Alex Teo from Singapore presented a study on multi-levels and found the same conclusions that you did, that a non-fixed kyphosis, you can restore or improve their lordosis with single and multi-level artificial discs. But right now, unfortunately, it's a qualitative, not a quantitative. And hopefully with more data, we'll have some guidelines like we do for laminoplasty. But your question about a fixed, rigid kyphosis, that's a no-go for me.
Great. We're almost at time. I'll ask Dr. Huang and Dr. Weichert to come up here. Thank you. Thank you, Matt. Thank you, Scott. Final comments. So first of all, thank you again for all your contributions. We have such a rich number of articles to choose from. And I think that this shows a very meaningful separation. You can access all these articles in the collections that are wonderful Mrs. Lieberman is putting together. So thank you for this work. Any thoughts in terms of GSJ and how we can learn from these kind of articles and draw conclusions for our practices? I'll start with you and then end with
Yeah. So thank you, Jens. I mean, first of all, this is a valuable thing that we're added to the Global Spine Journal. So thank you for doing that. Thank you for your partnership in broadcasting this and disseminating this. Speaking on behalf of the Global Spine Journal, we are the first open access major spine journal associated with the Major Spine Society. And we certainly welcome any evidence, any submissions to our journal, because we are open access. And if you publish with us, your article will get disseminated on a worldwide basis for free. So thank you for the opportunity.
And I want to add to that because obviously with the perfect opportunity of 25 years of cervical arthroplasty, we do have special collections on a bunch of other topics as well. And this is extremely helpful for authors. If you want to prepare a talk or give a lecture, write an article, whatever, you find all the articles on that specific topic sort of pre-collected for you, which have ever been published in Global Spine Journal. And this is very, very useful if you're an author as well. So yeah, please submit, and thanks for your attention today.
With this, we conclude. Thank you all for your assistance. May we have the 5 presenters up here for a group picture, and Donnie. Thank you all. JJ Pierce, John, come up here. Scott, come up here. Come in front of the dais.